Hi, hello everyone. Today we are going to discuss about breast cytology. So before goes to the sessions, please subscribe our channel, like our channel and share our channel. So for the more detail about medical related uh, lectures. So today we are going to discuss about the breast cytology. So in experimented hand, the uh, FNAC technique, fine needle aspiration technique for evaluation of breast lesion in highly uh, reliable. The average sensitivity is about 87 percentage and the specificity is closely to 100 percentage. So the predictive value of the positive diagnosis is nearly 100%. So when we consider the breast lesions, uh, it is maybe due to benign or malignant condition. So evaluation of the breast lesions, when we consider the fine needle aspiration tile cytology, this is the first line investigation and it is also highly reliable. When we consider the sensitivity, 87% sensitive, but when we consider the specificity, it is 100%. So predictive values for the positive diagnosis 100%. And hormone receptor studies, yes, we can do for that. So accuracy of the procedure, it is depending on the size of the lesion, aspiration characteristic, proficiency of the individual performing the aspiration, and the number of the needle passes. So here the most significant variable in the accuracy of the procedure are size of the lesion. So if it is smaller size, the accuracy may be low, right? So proficiency of the individual performing the aspiration, that means the expert is doing the FNAC, yes, they can easily aspirate it. The material from the FNAC, fine needle aspiration, is suitable for the hormone receptor studies also. And it should be always remembered that the negative or inconclusive cytologic findings are not to be regarded as a definitive diagnosis if there is clinically a suspicion of a malignant neoplasm. Right. Next is when we consider the interpretation and after FNAC, fine needle aspiration cytology is used as a first line investigation in the management of breast lesions due to benign and the malignant condition. We already discussed this. There are relatively specific cytological features that help to arrive at a diagnosis. So it is depending on first cytological features of an epithelial cells, and other thing is the quantification number of the epithelial cells, right? So accordingly, so features, cytological features, and the number of the epithelial cells, they can divide in the acute mastitis and fibroadenoma, benign epithelial hyperplasia, and malignant tumors. We can divide into four types. So first, when we consider first one, acute mastitis. So this is large amount of inflammatory cells we can see, right, when we interpret the lesions with the prominence of polymononuclear leukocytes, neutrophil we can see in the background of the cellular debris, because this is mainly due to the bacterial infection. Microorganisms and the protein precipitates also we can see. Smear may contain degenerate, normal or reactive duct epithelial cells. And in the acute mastitis in lactating breast, there are larger number of inflammatory cells and the cyst macrophages in the background of lipid secretion. So here most commonly in the postpartum period we can see this one. The bacteria invade the breast through the small erosions in the nipple of the lactating woman, and the abscess can result. So when we consider the cell type, we can see inflammatory cells in large amount. And other thing, polymorphonuclear leukocytes, that means neutrophil, we can see in large number. So when we consider the background, cellular debris, you can see microorganism, yes, can see, and the protein deposits, yes, can see. So degenerative and normal reactive duct epithelial cells also we can see, right, in the smear. And in lactatic breast you can see uh, what we can see in here, the larger number of inflammatory cells, that means uh, neutrophils and cyst macrophages, yes, you can see in the background of lipid secretion. So when we consider the fibroadenoma, so fibroadenoma, so the interpretation of the smears are highly cellular, showing cuboidal, ovoid, and spindle epithelial cells, often without cytoplasm. Here you can see the picture. So cells are arranged in tight cluster or large sheeted in the honeycombs appearance. So cells, the morphology is the cells are high cellularity. The different shapes we can see. It's maybe cuboids, ovoids, or spindle epithelial cells without cytoplasm. So cell arrangement, it is tight cluster or the larger sheets. It look like a honeycomb appearance. So next we will move into benign and epithelial hyperplasia. So this is a localized or diffused intraductal hyperplasia may produce a bloody or lemon yellow discharge, particularly when the present in terminal excretory duct. The discharge required to be differentiated from that the intraductal carcinoma and that the occurring during the pregnancy. The loosely clumped of ductal cells with acinus-like structure and dispersed barre nuclei are found. Some variation in nuclear size also can seen. So here you can see the normal duct and nuclear acids. So atypical hyperplasia in the duct. So you can here see very well the pictures. Next one, malignant tumors. So this is the very severe cases. So here um, so under malignant tumors, first one is the Chromadocarcinoma. So this is worm-like flux of a mixture of cancer cells and necrotic material may be expressed by nipple massage. So when we massaging the nipples, we can see mixture of cancer cells plus necrotic material. Microscopy shows variable number of hyperchromatic cells, usually single. That means normally 70% of the cells are single cells or in sheet and papillae or the cluster in the background of abdomen. The cluster in the background of abundant necrotic debris. The cell types are larger, pleomorphic, and show all the usual criteria of malignancy. So here you can see the picture very well. So normally hypochromatic cells, large various number, and most of the cells are single. Sometimes we can see sheet cells, seated and cluster background. And background sometimes we can see in the abundant necrotic debris. So when we consider the cell type, it is larger, pleomorphic, and so other malignancy criteria we can see in the cells. So here you can see malignant tumor, ductal carcinoma in situ. So how it is produced, here it is explained the picture. Under malignant tumor, next one is the infiltrating ductal carcinoma. So smear shows large number of sheets, irregular papillary projections, cluster and single cells. And cohesion of cells is poor and the tumor cells form loose clusters. In papillary duct carcinoma, clusters of hyperchromatic cells form papillary structures which can be easily detected in a cellular smear. So this is how the intraductal papillary lesions produce, right? So this is these pictures explaining basic fact for residents. So the number of lesions for here intraductal papilloma, central single or peripheral. When we consider the central area, it is single. Peripheral area, it is multiple. Papillae, when we consider the arborescent structure of the fibrovascular core, usually broaded fronts. So here next one is the myoepithelial cells. Peripheral area is present within the papillae. Also the presence in the intraductal uh, papilloma. Epithelial cells. This is non-neoplastic and apocrine changes common. May have the foci of UDH and squamous metaplasia if infiltration due to the needling or the torsions of fronts. So papilloma with ADH. So here number of lesions at center single but peripheral multiple. But in intraductal papillary carcinoma here multiple, right? The number of lesions. But encapsulated papillary carcinoma, we can see the number of lesions single. So papillae, when we consider papilloma with the ADH here, arborescent structure of the fibrovascular cause, usually a broader fronts. So in intraductal papillary carcinoma, arborescent structure of the structural core, usually cylinder fronts. So here you can see the picture. And in encapsulated papillary carcinoma, arborescent structure of the fibrovascular cores, usually cylinder fronts and surrounded by the fibrous capsule. So solid papillary carcinoma. So here multiple circumscribed solid masses in the contagious geographic patterns in conspicuous